Hello, hello everyone. My name is Eric Contant. I'm one of the emergency specialists at the Bráðadagurinn at the Landspítali, and today I would like to talk to you about the in-situ trauma simulations, its role, and challenges ahead. I would also like to thank Yardis, one of the nurse specialists working in the ER, and also Torek, who is a Hello everyone, my name is Eric Contant and I'm one of the emergency specialists working at the Bráðadagurinn at the Landspítali, and today I would like to talk to you about the in-situ trauma simulations, its role and challenges ahead. I'm very sorry of not being present in person. I think it's been way too long that since we gathered together, and I would have really liked to be there. And also I would like to thank Yardis, one of the nurse specialists working in the ER, and also Torer, one of the higher specialty training. They've been both essentials to these trauma simulations. So before moving ahead, I would like to do a bit of a background. I think it's interesting. The trauma committee at the Landspítali falls under the emergency department, and the chief of department usually appoints someone to direct it. This committee is multidisciplinary, involves range of specialties, pre-hospital, emergency medicine, nurses, ICU, and different surgical specialties. And it's interesting because for some people, the trauma committee equals these monthly exercise that we've been doing, but I think it's much broader than this. It's also responsible for protocols, training, simulation, and quality improvement. Usually the way it works when there is a serious trauma is that we have a trauma response team. We activate a button and then people come to the ER under the direction of the ER physician. This team, again, is a multidisciplinary, involves ER physician, ER nurses, Atsodaman, Shukralidi, the Ritari, ICU doctors, and surgery. And the combination of people, it can be quite daunting. People are rotating in ICU, in surgery, in ER. Nurses are rotating. And people have different habits and ways of doing things. So we see new faces. So one way of kind of like countering that is by doing these monthly trauma simulations. Anyone who's worked in the ER has probably been involved or has seen one. They're usually in situ, and we'll talk about what it means after. Usually the way it would work is that the operators would be one nurse and one ER physician. The procedure would be that we would call ER, ICU, and surgery for heads up. We would push a trauma button around 9 o'clock, and then we would simulate a major trauma, usually under low fidelity. So in situ simulation is basically a technique where the clinical teams would engage in a simulated clinical scenarios within the clinical workspace. So that's quite a mouthful, but what it means basically is it means doing simulation where people work and where they would see patients. And this contrasts to ectopic training, for example, going to the Ermerbergi, the simulation room downstairs, or going to Skaftaklit, where we have a lot of equipment and then we can practice stuff. But this does not really reproduce the challenges that we see on the daily life, like where do we stand next to the patient, or like how is the monitor, how does the suction work, where is the airway card, for example, or where do we reach for Brussels tape and where is it hiding in the ER. So this is where the advantage of in-situ simulation is. We also have some studies showing that in-situ trauma exercise work. One study identified latent safety threats, meaning identifying inefficient workspace, equipment problem, absence of a Shermantle model, or poor infection control methods. Another study showed that it increased confidence in trauma management, increased task completion, for example, doing a primary and a secondary survey, and also identifying a leader and dividing roles. Also decreased time for CT, and another study showed that it increased communication during trauma. Interestingly, in that study is that it showed that there was an effect, but this effect went away when practice stopped. Most of these studies have been doing with video recording feedback and also with high fidelity mannequin, something we've not been doing. So all of this looks pretty good on paper, but in the last couple of years we've been hit by COVID. This meant that meetings have been held. Initially, people have been focusing more on COVID. People have been sick, in quarantine, quitting, or in burnout. And despite this, the world continued to rotate during COVID, and trauma kept on continuing. For example, there's been some concern about increased conjugal violence, and also violence against women, children, increased sale of alcohol during COVID, and and also there's been some shootings also in the last year. Some things that people thought would not happen that commonly in Iceland has been occurred a few times, just within the last 12 months. So just to give you some rough numbers that we've accumulated over the last couple of years, from the educational year from August to May, we've done 2020 to 2021, we've done 8 practices. One has been canceled because of overcrowding in the ER department. Out of this, ER has been present in all of these exercises, of course. Surgery resident has been present in all of them also in 2020 to 2021, but no surgery consultant have been present, and ICU has been present 6 out of these 8 exercises. (2021), the year is still running. We've done so far 4 practices. One has been canceled due to overcrowding in the ER. Surgery resident have been present in all of the cases again. No surgery consultant have been present, and ICU has been present in 25% of the cases that we've been running this year. So we've had some challenges over the last few years. One of them, to my eyes, was the lack of space. Many times we've came to the ER in the morning doing these practices, and basically the ER was full, 20, 30, up to 40 admitted patients. All the recess rooms have been busy. So it's been very frustrating to just come and then having to abort a practice like this. Also, the lack of human resources. All of these patients, they need food, they need medications, they need their vitals, they need blood tests. So everyone is busy looking after them in the ER department, and little space, mental space also for doing a trauma exercise on top of this. The involvement of other departments also has been, I would say, suboptimal, and this is not to do any finger pointing or blaming anyone. I know that other departments find these exercises to be important and essential, but their presence is also essential, and the goal is to call them to be present so we can increase our communication and collaboration. And like I said, I know this is a priority for them also, but they also struggle with their problem. They might be busy in the OR. They also struggle with short staffing. Other challenges: time and money. Time, I've been lucky enough that my boss lend me some time that I can I can have some time and focus on these practices. And money hasn't been neither a big problem. We've been doing these practices lo-fi with a low fidelity mannequin, so money has not been a major problem. But if you think that time is money, money does. I've been lucky enough that my chief of other challenges, time. These would usually take about 30 minutes per training, but would require a physical space, some moving on to other challenges. These exercises would take a bit of time. I've been lucky enough that my chief of department has lent me some time to run these practices, but usually, we would have to show up in the morning, call all the teams, give the heads up, prepare the equipment, prepare the physical space, moving the mannequin, moving patients, call the consultant, talk to the ER in charge. So they've been taking a lot of time, And also money. Money hasn't been a major problem as of now because we've been keeping these exercises low fidelity with kind of like the lower hand mannequin, just to focus more on the communication and collaboration and workflow more than like the higher fidelity models. So where are we standing? I think everyone always appreciate these drills. I think everyone is frustrated when they don't have the opportunity to practice these, to participate into these drills. I think we need to continue. We need more people. We need more space in the ER also. We also need a increased presence from other departments. Again, like I said, this is not about finger pointing or blaming anyone. They also have their challenge. But we also need to make sure that everyone is on board with that. And also looking at the literature, having a video feedback seems to help a lot. People can watch themselves, where they were standing, the way they talk to other people. And I think this would be our next big step for us. So this is it for my presentation. Sorry again for not being present. I would have really liked to be there with you guys. And again, this was just a small overview of the work we've been doing lately. If anyone is interested in being involved into trauma or into the in situ simulations, let me know, and you can contact me at this email. And we're looking for basically anyone who's motivated from any different specialties and badge name on their badge. Thank you so much, and I'm saying bless, bless.